do this. But if you go back and just review these questions, the basic things that people are looking for right now in open enrollment, particularly for the populations that we're here talking about, that really are on 5, 6, 10 different medications. And they're really trying to do an apples-to-apples comparison of different types of health plans. It is a challenge. So if you look at these questions again, can I keep my doctor or my medicines covered? What are my total costs? We still don't have good information about that. Can I go to my local hospital? In covered California, there is ready access list to in-network doctors. It was challenging, as we've just seen, to find medications that patients are trying to see if they're in different tiers of coverage. There's helpful, but still some work to do in the cost calculations in terms of what my expected total costs are going to be if I enrolled in a particular plan. There was some helpful information we found for specialty populations, but HIV/AIDS was the only disease-specific special population. So I think just in closing, this is I think an ongoing challenge. I think that certainly California has been ahead of the curve in a lot of these issues. Certainly at the state policymaker level, some of the leadership that we've seen is very exciting. But certainly I think there's a host of challenges to make sure that the information is available. And I do want to challenge us to really think through this issue of the cost sharing and benefit design of some of the plans, particularly for these patients that we know predictably are going to be taking certain medications, and we want them to be adherent to those medications. We want to make sure that they're filling medications to manage these chronic disease and not have a plan design that really discourages it. So with that, thank you for your attention in coming this morning. I'm going to move on to the next session here, which is a panel discussion that is going to be moderated by Emily Bazar, who is a columnist and senior writer for California Healthcare Foundation Center for Health Reporting, also part of the USC Annenberg School for Communications and Journalism. I'll have to read her column, Ask Emily, which addresses readers' concerns and questions about the Affordable Care Act. It appears in more than 25 newspapers and NPR affiliate websites across California. It has generated nearly 2,000 direct questions and comments. In her role as Ask Emily, she regularly appears on KPCC's Take 2 and Air Talk, KQED's Forum, KALW's Your Call, and Valley Public Radio. So we're so happy that Emily is going to come up, moderate this panel, and she will introduce our panel participants. So Emily.
Thank you, Dr. Thorpe, and thanks to all of you for coming. As Dr. Thorpe said, I'm going to introduce this magnificent panel that we have, and then I'll make a few introductory comments before I let them loose. So let me start with the brief introductions, and I think they'll come up one by one. I'm going to start with Dana Malik. Dana is a member of the state and local campaigns team at the American Cancer Society Cancer Action Network. And in this role, Dana works with field staff in all 50 states on Affordable Care Act implementation issues. Her areas of expertise include coverage and affordability of prescription drugs, provider network adequacy, and health plan transparency, which are all things that I am sure we're going to be discussing today. Next is Larry Hausner, who was most recently the Chief Executive Officer of the American Diabetes Association, and he held this position from 2007 until actually just a few months ago, I believe. And as CEO of the association, he advocated for the passage of the Affordable Care Act. Larry also was appointed to the U.S. delegation I'm going to get this wrong, U.S. delegation to the United Nations Non-Communicable Disease Alliance. Next is Liz Helms. Where's Liz? Maybe she's in the room.
We need a battery charge.
Oh, she's getting charged. Okay, well, we'll skip Liz. Okay, we'll get you relaxed. Okay, we'll jump to Carl. Carl Schmidt is Deputy Executive Director of the AIDS Institute, and he directs the Institute's federal policy priorities before executive agencies and Congress. Carl also helps lead the, actually, Carl, I think, yes, right there, thanks. Carl also helps lead the I Am Essential Coalition, which helps ensure that the ACA works for patients, which is exactly what we're going to be discussing today. Thanks. Welcome. Just keeping my eye out for Liz there to see if she's ready to come up. Not quite yet? Okay. We'll give it one moment. Okay. And finally, we have Liz Helms. Take your time. Who's the president and CEO of the California Chronic Care Coalition, which is an alliance of organizations that are united to improve the health of Californians with chronic conditions. The mission of the coalition is to improve access to affordable and quality health care. Welcome, Liz. I wanted to start with a few brief introductory comments, as I mentioned. As Dr. Thorpe said, I write a column called Ask Emily, which is a consumer-oriented and completely consumer-driven Q&A column about Obamacare. And I've been doing this for nearly 2 years now, and as a matter of fact, today my 43rd column published. I never actually thought I'd get to 43, and that's because before we started with this experiment, we didn't meet, when I say we, I mean me and my editors, we didn't know how this column was going to be received, both by our media partners, which are newspapers and websites around the state, radio station websites, but especially by consumers. Did they want or need this information, and would they find it useful? I've got some statistics to answer this question. As Dr. Thorpe mentioned, I feel like I'm going in and out here. As Dr. Thorpe mentioned, I've received nearly 2,000 comments and questions from consumers, basically, around California primarily, but really around this country, and even from some overseas American citizens. The column is picked up by 25 newspaper and radio stations across the state. So, in other words, heck yeah. People were desperate for help and guidance about this very confusing law, and in fact, they still are. We are nearly 1 year into full implementation, or nearly full implementation of the ACA, and the questions just keep coming. Many are from people who are satisfied and happy with what they've received, but the majority honestly are not. I mean, they're motivated, they want to write to me because they have a problem. The truth is that the first year of Obamacare implementation in California and in the United States was rocky, and its effects on patients were inconsistent and uneven. As I said, some people have benefited greatly. Dr. Pan and Dr. Thorpe both brought up, and the columnists when I talked to them before this the panelists before I talked to them before this panel, all brought up the big thing, which is that you can no longer be denied based on your health condition. That's a huge impact and benefit for people. Other people are saving hundreds or perhaps even thousands of dollars a month or year on their health care premiums because they qualify for federal tax credits, which reduce the amount they pay out of pocket. Let's just look at the numbers, too, for some successes. More than 7 million people across the country are enrolled in marketplace health plans. And Californians make up more than 1 million, or more than a seventh of those who are enrolled in Covered California, which is our health insurance marketplace. Out of those 1.12 million, nearly 90% qualified for tax credits. Let's not forget the Medicaid expansion, which I think is a big undercovered thing in this ACA implementation. California, again, leads in the numbers. At least 2.5 million Californians are newly enrolled in Medi-Cal, which is our version of Medicaid, since January 1st of this year. At the same time, as the doctors before me have mentioned, there have been major challenges for consumers. The faulty Covered California and healthcare.gov websites continue to pose challenges for consumers to this day. However, things are definitely better than they were the first time around. The Medi-Cal application backlog in California still persists, and there are lawsuits over this. Covered California have canceled people's plans over the course of the year without their knowledge or their consent. Translation issues for people who don't speak English as their primary language. And perhaps consumers' biggest complaints revolved around provider, narrow networks and provider access. So today we'll be discussing some challenges that have hit people with chronic conditions in particular, and these have been brought up before. The specialty drug tiers that have people paying, in some cases, thousands of dollars at a time for certain drugs, and high out-of-pocket costs if people want to visit their doctors or get a lab test. These are going to be the subject of this panel. But let me end by describing my most recent Ask Emily column. I was getting a lot of questions from people who were 64 years old or their husband was or something like that, but they were getting close to aging into Medicare. And they were Covered California, or they are Covered California customers, and they wanted to know if they should keep their Covered California plans after they enroll in Medicare. So I did a little bit of research, and it turns out that you become ineligible for tax credits once your Medicare coverage begins. And if you keep your Covered California plan and keep getting those tax credits after your Medicare begins, you will be on the hook to the IRS, and you will have to pay back any of those tax credits that accrued after your Medicare began. Not a lot of people knew that. I didn't know that. So I wrote that in my column 2 weeks ago. You know, the advice I gave people, easy enough. Drop your Medicare, excuse me, don't drop your Medicare. Drop your Covered California plan when your Medicare starts. Simple advice. Well, that column published, and my inbox got jammed with emails from people who have tried desperately to drop their Covered California plans, but have been unable to do so. They've been on the phone on hold for hours. They've made calls to their health plans. They've done online chat if they could get the online chat function working. They got mired in this bureaucratic nightmare with Covered California and the health plans pointing fingers at each other. They simply could not cancel their plans. So, this is not just an ad for Ask Emily. That was the subject of my most recent column, and I think you guys will appreciate the headline. The headline of this column is, "It's not easy to check out of the hotel Covered California." But I raise this example because it's indicative of what has been happening to many consumers in this past year. Things that should have been simple, in many cases, have not been. But there's hope. As you know, we're in the second open enrollment period right now, and it goes through February 15th, and so far things look to be going a little bit better. So, now I'm going to let this blockbuster panel take over here, and we'll be talking about some of the successes and challenges for patients in the past year, but hopefully we can also look ahead a little bit to what's coming and what may get better. For those of you who are inclined to tweet, there's a hashtag, it's PFCD in CA, and it's on that slide right there. Off we go. Okay, this is working. So I called everybody on the panel last week and talked to them before this, and I asked everybody, what is the biggest success of the ACA for patients? And each one of you said the exact same thing, and that was guaranteed issue, the fact that anybody is going to be able to get health coverage or health policy because they can't be denied for pre-existing conditions. So I'm going to put you guys on the spot a little bit, and I'd like you to talk about that if you want to, and how big a deal that is for people with chronic conditions, but also what else has been a big success for consumers in this past year. And I'm going to start on the end there with Dan.
Thanks, and thank you all for having me here today. I mean, exactly as all of my colleagues here have said, guaranteed issue, being able to get health insurance no matter what, even if you have a pre-existing condition like cancer has been a huge deal. I think in our facts and figures report, it was estimated 172,000 people in California would be diagnosed with cancer in 2014. So huge, huge deal. Medicaid expansion as well. I mean, this is a population that up until this point has not been able to have access to, afford, of course, any kind of health insurance in the private sector, but you know, in addition to that, have also not been able to get any sort of preventive services, chronic disease management. So being able to get those individuals covered through Medicaid expansion for states that choose to do so is also a huge win. And I think kind of, another thing that you and I discussed earlier, which I always try to say is also a win, and not to shift to negative, but a lot of the issues that we're going to talk about that are challenges have existed far before the ACA was ever passed and implemented. So things like having difficulty finding out what doctors are covered, having difficulty finding out if your drugs are covered, just understanding health insurance in general. That's always been a challenge, and the ACA has really kind of pushed us to start having those conversations again about how to fix those problems, and I actually see that as a huge positive to the ACA passing as well.
That's an interesting idea, that transparency was a problem. It's
Sure.
still a problem,
Sure.
but it's hopefully going to get
We're talking
better.
about it.
Yeah,
Again.
yeah. And I hope you guys, since we're seated this way, that it will be a discussion, so you guys can kind of jump in, and I'll direct you at some points. But who wants to go next? We'll go on forward.
Because I'll pick up on that last point that you made about education. Because you have the Affordable Care Act, and the options that are available are just so much better than it was before. But it's only better if you know what to do. And it's only better if you know where to go. And some of the things Dr. Thorpe talked about with the system, someone has to help you get through that. Someone has to be able to educate you, and for you to understand what your self-responsibility is, how you can self-manage, and then how you can get involved with shared decision-making. If that's shared decision-making with your family, or shared decision-making with your healthcare provider, or shared decision-making with the advocacy organization that you work with. But it's very important, because no matter how good the system is, if people aren't able to access it and understand it, it won't take us to the next step. And we can't forget that this is a new purchase for just about everybody in the United States. No one knew anything about healthcare, except that they had a card, and you walked into your doctor and you gave it, and you hoped that it didn't cost you too much when you walked out. And this is a whole different area. One of the things, if it's okay, Emily, I wanted to give an example of the good that has happened with the Affordable Care Act when it was introduced. And this is, I'm going to read an excerpt from a blog of somebody who has diabetes, has had diabetes since they were 9 years old. They're now around 29, 30 years old. And this was during the first year when she went onto the website. And she lives out here in California. And she had been someone lucky enough. She always had insurance. She didn't have any problems. She was someone that was well off, and her family was well off. So it was coming from, it wasn't that this is a new thing for her to have health insurance. It was just the availability of the Affordable Care Act. And it says, now remember, I'm her, not him. So on October 1st, I went to my state's ACA exchange, covered California. But non-committal as I was floored by what I saw. I filled out the simple questionnaire on the website to see my options. They asked me about my age, my income, my family size, and that was it. No medical history. No, do you have diabetes? No, are you more likely than average to get kidney disease and retinal disease and neuropathy? No, do you cost a fortune because of all the medications you need? No, have you already had cataract surgery because of this stupid disease? Age, income, family size, and then I was presented with options. The same options my healthy young male husband sees. The same options every late 20-something sees. It's an amazing feeling. After almost 2 decades of feeling tied to a single option, an option I like and I'm extremely grateful for, but still a single option, I felt liberated. Even now I get chills just thinking about that feeling of hey, you're just one of us now. It's incredible. It's profoundly American to feel like I have choices and the freedom to move. Death and taxes may be all that we're guaranteed, and you can argue back and forth about whether healthcare is a national right, but you'll have to excuse me while I sit here and enjoy this intoxicating sense of liberty I've just been given. And I think we need to not forget that when we get into the issues.
Well, that's actually very touching. I bet she saved a lot of money, too.
Yes.
So.
Liz, is there anything specific to California that you wanted to mention?
Sure, and that's very heartfelt and really, sums up what people have had to go through when they couldn't get insurance, and the fights that we had for any little pre-existing condition where you would be excluded from being able to purchase some type of health insurance, health coverage. So we're very happy about that. And we have lots of good things to say about Covered California. We've worked very hard with them. We continue to work with them. They're very open to listening to our explanations and our comments and our concerns. And we have one of our members that has not missed, I don't think, a single meeting since they've had them. He's a fly on the wall. That's Jerry Jeffy sitting over in the back. He's our public policy director, and he can tell you, he would actually remember every conversation that they had in every single meeting since they started. So that's really good that there's a lot of openness. The literacy is a huge issue, and so unfortunately, as much as I am, and we want them to succeed. We want people to be able to access the care that they need, and get a culture of health rather than a culture of health care. We can do that as we move over into prevention. So there's a lot of work that still needs to be done. My list actually, though, on the other side is probably longer than the good.
I figured that's why we're starting with the good. But Carl, do you want to jump into this?
Sure, I think a lot has been said already, but our country, we have 40 million people, lacking health insurance. That's a lot of people. So the opportunity for individuals to gain health insurance and health coverage is great, and not to have that pre-existing condition as a barrier as well. And Medicaid expansion is really key as well. Again, before you really had to be very poor and have a health condition, but now that's been taken out. You just have to be poor. It depends. It used to depend on the state, and now it's around the whole country if each state accepts it, and that's one of the problems. Not every state is accepting it. So the opportunity for coverage, and for people living with HIV, less than 20% actually had private health insurance in the past. So this is huge, both the Medicaid expansion and the opportunity for the private market. And just to, I think coverage is key for when you're sick, but as Dr. Thorpe mentioned, and you as well just now, the preventive services is something that we really have to focus on as well. It's not as, it's not as discussed as much as the other, elements of the Affordable Care Act, but the opportunity for free screenings and tests, other tests, is in counseling is really something that we need to focus on as well.
Carl, you mentioned fewer than 20% of people with HIV. Do we know what it is now or have any estimate?
I don't think it's gone up that much yet. Unfortunately, a lot of people live in states that are not expanding Medicaid, particularly in the South, and a lot of people with HIV, I think, were very confused last year, and I think when we talk about some of the issues of high cost of drugs, it was another barrier.
Oh, I think we filled our positivity question. I think it's time to start talking about some of these other issues.
I don't know, I still feel pretty good for
It's nice aura. I do want to throw out one statistic that's pretty amazing about Medicaid before we join. California now has 11.3 million people in this state who are covered by Medi-Cal. That is nearly 1/3 of our population. That's monumental. So, and it's a program that is suffering because, well, we can go into that another time. But let's go to this.
I just wanted to add something, the last thing Carl said there, dealing with prevention, and still staying on the positive side. And so with the Affordable Care Act, with diabetes, there's 29 million people in this country with diabetes, and over 25% of them are undiagnosed. Part of the reason they're undiagnosed is because they don't get screened for diabetes because it's not covered in the plans that have been out there in the past. Recently, the United States Preventative Services Task Force, I always get those letters wrong, the Preventative Services Task Force just expanded who can be screened for diabetes, and now it's more by risk factors, and risk factors that tie specifically into reasons where more people might get diabetes. And they were able to do it because of the coverage around the Affordable Care Act, and it tied together, which will bring down those costs associated with it, as well as will have better care for people who get diagnosed with their diabetes earlier in life and can take better care of themselves and have less complications later.
That's a very good point, yeah, thank you. Well, let's talk about, everybody here has talked about what a big deal it is that you can't be discriminated against when it comes to buying a health plan. But let's talk about if there's discrimination within health plans. And this goes to the issue of the prescription drug costs, perhaps other copay costs. Can you guys address this idea of, is there still discrimination in health plans, but maybe it's just in a different form? Who wants to start? Carl.
Okay. Unfortunately, yes. So what we're finding is, looking at HIV drugs, hepatitis drugs, and other disease groups as well, is what there's some plans, it's not all plans, and this is why it's discrimination. That for the same exact drugs, people say, oh, HIV drugs, they're expensive, Well, what we're finding is, some plans are charging $10, $50 copays. People can access their medications, maybe $150. But other plans are putting all the drugs to treat HIV, all the drugs to treat other diseases, chronic diseases, on the highest tier, and charging huge co-insurance at the same time. 30%, 40%, even 50%.
What does that mean in terms of dollars?
Lots of dollars. So, maybe a treatment is, over $2,000. And people living with HIV and other chronic diseases, that's why they're chronic, it's the rest of your life. And so it translates, they don't know, that's one of the problems, they don't know what 50% of what is, and we'll talk about more later, hopefully, about the issue of transparency, but just turning to discrimination, that some plans are putting, the drugs in the same class for the same condition on the highest tier. And we feel that's discrimination. We are based in Florida, and we actually filed a complaint with the Office of Civil Rights at the U.S. Department of Health, and claiming that this is discrimination.
Is that a recent
We did it in this past May, and we're not seeing any progress. We're seeing the same, that's just based on the 2014 plans, and we are seeing the same exact things for 2015.
Are you talking nationally, or are you talking California specific?
I
I'm sorry for interrupting, but that's
please.
a huge
I'm
point.
glad. I'm glad.
So I could give you specific examples of Florida, but then we, did this action, and people, and we just looked at HIV as well, and hepatitis, and we heard from so many other states that it's happening, including California, and other disease groups as well, that we're not alone.
Liz, why don't you address the California side?
Sure. Thank you for asking that, because we've been very involved in the discrimination issue when we saw it starting to have its ugly head shown. And we felt that this might be where they're putting people with pre-existing conditions or chronic diseases into these higher cost areas for co-insurance. When we started looking into California law, we found that the Unruh law many, many years ago, several decades ago, stated in it that people not just of color or ethnicities, but people that had disabilities or medical conditions could not be discriminated against. we felt that at that point, by carving people out with chronic conditions and putting them into a place where they're going to hit their out-of-pocket, you know, they can hit that in January, February. They're going to walk in and they're going to say, not only do we have a premium, even if I have a subsidy on my premium, and I did, yesterday I worked out something that was really alarming to me on a $45,000 income person. But if you take all of that and you move it over into co-insurance, we think it's inherently illegal. And we have started that conversation. We have legal opinions. We have been working with the Department of Insurance. We are going to be heading over and working with the Department of Managed Healthcare. We want to work with Covered California. We have a legal opinion saying it is illegal in the opinion. And it's really energized all of our organizations like I haven't seen in a long time, to say we've got to do something about this because people are not, it is unaffordable and it's inaccessible. So how do we build quality into a system that doesn't allow people who are the sickest, who need the care the most, the ability to get the medicines that they need to keep them well, to keep them at work, to be taxpayers, to be doing all the things that they need to be doing to be a good citizen and be able to manage their chronic disease. And so yes, we are totally, in fact, we've been working with the AIDS Institute out of Florida. We had the NHELP come in and do our webinar. So what we started now has been a national discussion called, we call it RxSOS, and it's the National Stakeholders Medication Specialty Collaborative. And it's been phenomenal in the discussions, and we want to find answers. We don't want, just to blast everybody. We want it to work. We have opportunities for that to happen, but it's everybody's voice at the table.
Just so we understand, so you're, and I don't want to put words in your mouth, I just want to understand that, so you view Knox-Keene in California insurance law as insufficient, and so you're attacking the issue that was raised using the Unused Civil Rights Act? Am I
We're
understanding
using the
correctly?
Unused Civil Rights Act, but we're not saying that there isn't regulatory authority already for regulators to make decisions without filing lawsuits.
Okay.
Dana, did you want to?
Yeah, I mean, I think what you're saying gets to the heart of the issue. The challenge is that the ACA, there's a couple of different provisions that address discrimination, but one of which is that you can't discriminate in the space of essential health benefits for a couple of different things, one of which is other health conditions, which is very arbitrary. And so there hasn't been much of an effort to more clearly define what that means, and like so many other parts of the ACA, I think that sort of codifying an enforcement mechanism has fallen to the states. And so this is, I think, what a lot of states have started down the path of doing, is really trying to, at the state level, define what discrimination or discriminatory benefit designs means for other health conditions, something that is prohibited in the ACA. And I think that's probably what we're going to have to do unless HHS makes an effort to more clearly define what that means, which has also been a challenge pre-ACA. So.
And we hope that our, complaint, there's a number of reasons why we filed a complaint. And it's just not Florida, it's just not HIV. It is to put insurers on notice that we're watching. And we've met with the National Association of Insurance Commissioners, and they really are encouraging patient groups to file complaints. That's how they, with your